Single fiber EMG is a selective electromyographic recording technique that allows the identification of action potentials from single muscle fibers. The electrode has a recording surface on its side that can be positioned very close to one or a few muscle fibers. The action potentials from these fibers can be distinguished from those produced by more distant fibers. The active recording surface is a 25 micron diameter wire which exits on the back of the electrode, 3 millimeters from the tip. The white material insulates the active electrode from the cannula. Recordings are made between the active electrode and the cannula. This figure demonstrates the relative dimensions of the electrode and the muscle fibers. The fibers from one motor unit are represented by the polygons that are lighter in color. Here the electrode has been positioned so that the recording surface is very close to one muscle fiber in this motor unit. The semicircle of 300 microns diameter indicates the recording area of the electrode. In most normal muscles, when this electrode is placed very close to one fiber, such as this, there will be at most one other fiber from this motor unit within the recording territory. Here the dots distributed through the circle indicate the random distribution of muscle fibers in a normal motor unit. The small semicircles indicate the recording territory of the single fiber electrode when it has been placed very close to one muscle fiber. Only one muscle fiber is within the recording territory of the electrode and about half the recording sites in a normal muscle. In recordings from these sites, we see only a single action potential. In about half the sites, the recording territory contains two fibers, as here, and we see two action potentials. After reinnervation, muscle fibers belonging to a single motor unit are grouped together, as here, rather than being randomly distributed throughout the muscle. When the electrode is placed close to one muscle fiber, we record action potentials from many other fibers as well. For single fiber EMG recordings, the EMG equipment must have a low frequency filter of 500 Hz. The high frequency must extend to at least 10 kHz. We must be able to trigger the oscilloscope from the EMG signal and delay these signals on the display. Fiber density measurements are performed while the patient voluntarily activates the muscle. Many muscles in the body can be tested by single fiber EMG. The extensor digitorum communis muscle is frequently used for both fiber density and jitter measurements. This muscle is easily located, easily activated by the patient, and relatively free of the age-related changes that are found in some other muscles. The patient activates this muscle by lifting the middle finger. Only slight contraction of the muscle is necessary. Contraction of the muscle can be felt just under the skin. The electrode is inserted 2 to 3 finger breadths distal to the lateral epicondyle. As the patient activates the muscle, the electrode is positioned by rotating it and moving it slightly in and out until acceptable action potentials can be recorded. Only very slight movements of the electrode are necessary. Single fiber action potentials typically have amplitudes of 500 microvolts to 5 millivolts, though they may be up to 20 millivolts. They have simple waveforms with 2 or 3 phases and spike duration less than 200 microseconds. For fiber density measurements, action potential should have an amplitude greater than 200 microvolts and rise time less than 300 microseconds. Using these criteria assures that the electrode is within 300 microns of the muscle fibers producing the action potentials. To assure that the electrode is as close as possible to one muscle fiber, observe what happens to the action potential amplitude when very slight movements of the electrode are made. When the amplitude is maximum, we look to see how many other action potentials are time-locked with this potential. That is, how many potentials other than the trigger are seen at a constant position on the screen. In this recording, there is only the triggering potential. Thus, for this site, we record a fiber density value of 1. The electrode position is then changed, and another action potential is sought to trigger the oscilloscope. The electrode is again positioned until the amplitude of this potential is maximum. Then we look for other spikes that are time-locked to the triggering potential. Here we have two spikes that are synchronized. For this site, we record a fiber density value of 2. Fiber density recordings like this are made in 20 different electrode recording sites throughout the muscle. The electrode is moved a few millimeters between recording sites. 5 to 7 sites can be examined with each skin insertion. And 3 to 4 skin insertions are necessary for each muscle. The average number of fibers recorded in these 20 sites is calculated. This is the fiber density for this muscle. The results are compared with reference values for the muscle tested. Since fiber density increases with age, especially after age 60, results must be compared with values from the appropriate age group. To measure the neuromuscular jitter, we seek an electrode position where action potentials from 2 muscle fibers, innervated by the same axon, can be recorded. With the electrode in this position, we see pairs of recurring time-locked potentials as here, when the patient voluntarily activates the muscle. If we trigger the oscilloscope on the signal and delay it for display, we can assess variations in the intervals between the 2 potentials of a pair. These variations are seen as variations in the position of the non-triggering action potential on the oscilloscope screen. This is the neuromuscular jitter. The optimal electrode recording position for measuring neuromuscular jitter between 2 action potentials is usually not the position at which either of the individual action potentials is maximum in amplitude. This is different from the recording position at which we perform fiber density measurements. We have triggered the oscilloscope on the rising portion of the first potential of this pair. Thus, this potential appears at a fixed position on the screen. The neuromuscular jitter is seen as slight variations in the position of the second potential. If we trigger on the second potential, as here, the jitter appears as variations in the position of the first potential. In this motor unit, we have recorded 3 potentials, triggering on the second. Jitter is seen as variations in the positions of the first and the third potentials. There is increased jitter in this pair of potentials. Jitter is increased in this pair of potentials. There is also blocking. The second potential intermittently fails to appear. To adequately assess the neuromuscular transmission in a muscle, it is necessary to measure jitter in up to 20 pairs of potentials. The electrode must be moved sufficiently between sample sites so that we do not record more than once from the same pair of potentials. The neuromuscular jitter is quantitated by calculating the mean difference between consecutive interpotential intervals, or MCD, from this formula. Many commercially available EMG machines now can record single fiber EMG signals and make calculations of the MCD. Jitter normally varies among the pairs of potentials within any muscle, and the normal jitter differs among different muscles. To determine if the jitter within a muscle is normal, it should be compared with normal values for that muscle. Single fiber EMG can be performed in many muscles. The frontalis is frequently examined in patients with myasthenia gravis. This is a thin muscle and the electrode must be inserted obliquely. The patient activates this muscle by opening the eyes. Motor units in this muscle fire more rapidly than in limb muscles. Note that very small movements of the electrode produce marked changes in the amplitude of the action potential. The inferior orbicularis oculi can be examined by placing the electrode just beneath the skin, under or lateral to the eye. The patient activates the muscle by squeezing the eyelids closed. The electrode tip is angled away from the eye. Motor unit potentials in this muscle tend to be quite complex, even in normal subjects. The mentalis muscle is activated by pursing the lips. Jitter is slightly increased in the muscle in this patient who has had facial palsy. To examine the tibialis anterior, have the patient dorsiflex the ankle before inserting the needle. Shortening the muscle with the needle in place is more painful and may bend the electrode. The principles involved in examining these muscles can be applied to studying many other muscles. Jitter may also be measured as the nerve is stimulated. In the extensor digitorum communis muscle, the intramuscular nerve can easily be stimulated with a monopolar needle placed into the end plate zone of the muscle. A surface electrode can serve as the reference for stimulation. When the stimulating needle is properly placed, very low intensity stimulation causes a portion of the muscle to twitch. Feel where the muscle is twitching distal to the stimulating electrode. Insert the single fiber EMG electrode into the twitching portion of the muscle. Position the recording electrode until single muscle fiber action potentials can be identified on the oscilloscope. Reduce the stimulus intensity until only a few clearly defined action potentials are seen. The stimulation rate can be varied. Even at high rates, stimulation may barely be felt by the subject. The jitter between stimulus and response can be seen at faster oscilloscope sweep speeds. When the stimulus is barely above threshold, jitter may be introduced by variations in effective nerve depolarization. Great care must be taken to measure jitter only when the stimulus is high enough to avoid introducing this artifactual jitter. If the muscle fiber itself is stimulated by the intramuscular electrode, the jitter will be abnormally low, less than 5 microseconds. Recordings with low jitter must not be used for jitter calculations. Jitter measurements made during voluntary activation are not as prone to misinterpretation and should be mastered before stimulation jitter studies are attempted. Jitter can be measured during neurostimulation in many muscles. To examine the orbicularis oculi or frontalis, the facial nerve can be stimulated either with a needle electrode as here or with surface electrodes placed anterior to the ear. Stimulation with surface electrodes may introduce a small amount of technical jitter due to variations in conduction of the stimulus to the nerve. This tape is presented as an introduction to the technique of single-fiber EMG recording. It should be complemented by reading about the theory of single-fiber EMG and the applications of the technique. Single-fiber EMG can add considerably to the sensitivity and specificity of electromyographic examinations in many diseases. It will take time and practice to develop competence with fiber density and jitter measurements. We hope this tape has been useful to you in beginning to master the technique.
This program has been designed to present clinical examples of commonly encountered electromyographic findings. Patients have been selected to exhibit the various abnormal potentials regardless of the underlying disease process. All potentials are displayed on a TECA TE4 electromyogram. By convention, positive potentials will be below the isoelectric line. Frequency responses have been set at 16 Hertz and 8 kilohertz. The voltage and time settings will be displayed with each of the potentials. Waveform amplitudes are measured peak to peak. Duration is measured from the first detectable takeoff from the isoelectric line to the final return to the baseline. Wave configuration is described by the number of phases of the action potential. The number of phases is one less than the number of baseline crossings of the waveform. Waveforms of 5 or more phases are considered to be polyphasic. Since different electromyographic machines have a variety of physical scale factors for the oscilloscope calibration, the actual size and shape of the waveforms may appear to be somewhat different on the equipment you routinely use. 27-gauge Teflon-coated monopolar needle electrodes are used throughout this production.
Your attention should be focused on needle movements, observable muscle movements, and the simultaneously observed electrical potentials. Each example will be repeated after discussion of the waveform characteristics and underlying electrophysiology. Potentials will be presented in the sequence that they are normally studied during a clinical EMG examination. This will consist of the muscle at rest, followed by insertional and post-insertional activities. Voluntary muscle contraction patterns ranging from single motor unit activity to full interference patterns will be presented. You should feel free to stop the videotape and repeat any portion that you desire to analyze more closely.
With movement of the needle electrode into muscle tissue, brief bursts of electrical activity are observed that sound like crisp bursts of static. Insertional activity normally lasts a few hundred milliseconds. The duration is a function of the rate of movement of the needle electrode and the volume of viable skeletal muscle that has been penetrated. Insertional activity is felt to represent mechanically initiated injury potentials. Two abnormalities have been defined concerning insertional activity. decreased or absent insertional activity indicates either a reduction in the number of functioning skeletal muscle fibers or that the electrode is not moving through muscle tissue. Increased insertional activity beyond the normal duration is felt to indicate electrical instability of the muscle cell membrane. Once again, observe normal, decreased, and increased insertional activities.
In the muscle at rest, electrical silence should prevail. It is important to obtain relaxation of the muscle either by passive positioning or by contraction of the antagonistic muscle groups. Voluntary activity may mask pathologic findings. End plate potentials may be found in normal relaxed muscle and are of two types. End plate noise potentials are monophasic and negative in deflection. They are small in amplitude, 10 to 100 microvolts, and of short duration, 1/2 to 2 milliseconds. They occur at high frequencies. They represent non-propagated depolarizations of the skeletal muscle membrane resulting from the release of individual packets of acetylcholine in the end plate zone, similar to miniature end plate potentials. Over the speaker, the sound is similar to that heard when placing a seashell to the ears. Biphasic end plate potentials, which were formerly called nerve potentials, are larger in peak-to-peak amplitude, ranging from 25 to 200 microvolts. Their duration is usually 3 to 5 milliseconds. The firing rate is 5 to 50 hertz. The propagated diphasic potential is initially negative in deflection. They probably represent traumatically induced, propagated individual muscle fiber depolarizations. They have a crisp, sharp, high-pitched sound. These are often associated with significant pain, which is relieved by slight movement of the needle. Observe these normal end plate potentials once again.
With both the muscle and the needle electrode at rest, both fibrillation and fasciculation potentials may be observed. Fibrillation potentials are action potentials of single muscle fibers, or in some instances, a few muscle fibers. They are not initiated by nerve impulses, but occur either spontaneously or in response to mechanical or chemical stimuli. The sound is high-pitched, resembling rain on a roof or the crinkling of crisp tissue paper. Fibrillation potential peak-to-peak amplitudes range from 10 to 600 microvolts, and the duration is usually 1 to 2 milliseconds. The waveform is commonly diphasic or triphasic and is initially positive in deflection, except when in the region of the end plate of the muscle. The frequency of firing is 2 to 30 hertz, and the rhythm is regular. The upper frequency cutoff of the amplification must be adequate to observe these high-frequency potentials. Fibrillation potentials can be facilitated by warming the involved area, massage, or by drugs such as tensilon or neostigmine. Fibrillations tend to disappear with moderate cooling of the muscle and/or hypoxia. Fibrillation potentials are commonly found in lower motor neuron disease. They have also been shown to be present transiently in upper motor neuron disease. They are most pronounced in peripheral nerve injuries, but may be seen in myopathies, especially in muscular dystrophy. They are also found in botulism, polymyositis, dermatomyositis, and hyperkalemic familial periodic paralysis. The extent of fibrillation potentials may be quantified. Plus minus. Fibrillation activity noted only during needle insertion, but there are no other spontaneous fibrillations. This finding may be equivocal at times, convincing at others. 1 plus. Single fibrillation potentials discontinuously active noted in some samplings. 2 plus. 1 or a few fibrillation potentials noted in many samplings discontinuously active. 3 plus. Continuously active fibrillation discharge easily found in most samplings. 4 plus. Many continuously active fibrillation potentials noted in all samplings of positively involved muscles. Once again, observe these fibrillation potentials. Fasciculation potentials are motor unit action potentials of either normal or abnormal size and configuration occurring spontaneously and sporadically. They represent the spontaneous firing of either a whole or part of the motor unit. They may or may not be visible as twitches of the muscle. Fasciculations may be seen in diseases involving the anterior horn cell or more distal irritative diseases. They are also found in metabolic disorders. To identify fasciculations, it is necessary to be sure that the motor unit firing is not under voluntary control. Various maneuvers, such as attempting to increase or decrease the firing rate and firing antagonistic muscle groups, may be used. Discharges occurring at rates not within the voluntary control range are also diagnostic. Review fasciculation potentials. Myochymia is a rare finding of spontaneous synchronized contraction of large muscle fiber bundles. Waveform is similar to small normal motor unit patterns. A rhythmic pattern of activity is the pathognomonic feature. Now observe this demonstration of myochymia.
Biphasic positive waves are provoked potentials observed when the needle electrode passes through irritable muscle membranes. They have an initial short duration positive deflection followed by a prolonged lower amplitude negative phase. The total duration may approach 100 milliseconds and the peak-to-peak amplitude may vary between 50 microvolts and 1 millivolt. They are repetitive discharges, usually in the 10 Hz range. They often show a characteristic decay in firing rate, with increases in successive intervals until they disappear altogether. The amplitude may diminish in successive discharges as well. They are heard as a characteristic dull thud. The origin of positive waves is in dispute, but they probably represent either single fiber discharges at the needle tip or synchronized muscle fiber discharges at the exploring electrode. Representing membrane instability, the positive waves may be seen transiently in upper motor neuron diseases or in lower motor neuron diseases. They are the first pathologic potentials to occur in denervation. Positive waves are graded as follows. 1+, occasional positive waves present after moving the needle electrode. 2+, several positive waves present after moving the needle electrode. 3 plus, in between 2 plus and 4 plus. Cathode ray oscilloscope screen filled with positive waves. Bizarre high-frequency potentials are repetitive discharges with a variety of waveforms that may resemble positive waves or normal or polyphasic motor unit potentials. These potentials may be seen in any irritative lesion of the anterior horn cell, peripheral nerve, or skeletal muscle. They should be regarded as indicative of membrane instability, but their origin is unknown. The firing rate is constant and the activity starts and stops abruptly. They are distinguished from myotonic discharges in that they do not wax and wane. They are initiated by needle movement, muscle percussion, or voluntary activity. Recurrent action potentials at constant high frequencies, usually exceeding 50 per second, are termed iterative discharges. Rapid firing trains of positive waves following movement of the needle electrode represent one type of these potentials. Now review these bizarre high-frequency potentials and iterative discharges. Myotonic discharges are repetitive discharges in positive wave or motor unit potential configurations. They are characterized by a dive bomber sound, which may be observed on the oscilloscope screen as alterations in the amplitude and firing rates of the various different units participating in the discharge. These discharges are occurring at firing rates from 20 to 150 Hertz, and they may be initiated by needle movement, muscle percussion, or voluntary activity. Myotonic potentials have been observed in myotonia dystrophica, Steinert's disease, myotonia congenita, Thompson's disease, hyperkalemic periodic paralysis, Duchenne's muscular dystrophy, thyrotoxic myopathy, dermatomyositis, polymyositis, and acid maltase deficiency. Once again, observe these myotonic potentials.
At low levels of voluntary muscle activity, individual motor unit potentials are observable. These represent the summated membrane depolarization of muscle fibers innervated by a single alpha motor neuron. The typical biphasic or triphasic waveform is a result of the spatial and temporal algebraic summation of the various components. Normal amplitude, duration, and waveforms are a function of a variety of physiologic and instrumentation factors. These include the needle electrode type, amplifier input impedance, amplifier frequency response, the specific muscle being examined, the age of the subject, and the temperature of the muscle. Peak-to-peak amplitudes range from 300 microvolts to 5 millivolts. The normal motor unit total duration is 3 to 16 milliseconds. A typical minimum contraction firing rate is 5 to 15 hertz. At stronger contraction efforts, larger amplitude units with more rapid firing rates are observed. The most rapid firing rates approach 50 hertz in the peripheral muscles. The sound is a clear, crisp, sharp pop. Observe normal single motor unit activity. Now observe a slow progression from minimum contraction to full recruitment. In the early stage of reinnervation, polyphasic, low-amplitude potentials of increased duration are observed. These nascent potentials represent the restoration of nervous control over the skeletal muscle fibers. This process involves only a few skeletal muscle fibers and immature, slow-contracting terminal nerve twigs. Thus, there is little synchronization of the individual muscle fiber potentials. As the process of regeneration matures, more skeletal muscle fibers will be added to the motor unit, with greater synchronization occurring and larger amplitude potentials will be observed. motor unit potentials consisting of 5 or more phases with a duration greater than normal may represent a chronic neuropathic process. This motor unit potential represents reorganization of the motor unit where skeletal muscle fibers of denervated motor units have been incorporated into an existing or regenerating one. The sound has a rough, rasping, or chugging quality. There is often poor control over the firing rate of these units, and they discharge at velocities greater than anticipated for the strength of the muscle contraction which is produced. Giant voluntary motor units greater than 5 millivolts in amplitude with normal or increased duration and phases are observed in chronic neuronal diseases. They are the end stage of the reorganization of the motor unit whereby denervated fibers are incorporated into surrounding healthy motor units. They are most common in anterior horn cell diseases. Small amplitude motor units of short or normal duration result when fewer than normal skeletal muscle fibers participate in a motor unit discharge. These motor units are often polyphasic as well. Primary muscle disease is the usual setting for these potentials. The voluntary control over the firing rate is usually preserved.
When given visual and auditory feedback of motor unit activity, most subjects can quickly develop control over the firing rate of one or more motor units. When progressive increases in strength of contraction are elicited, units may be seen to fire at increasing rates and be accompanied by more and often larger amplitude units. At maximum contraction efforts, the baseline on the oscilloscope screen is obliterated by the activity. This is called a full interference pattern. When motor unit reorganization has occurred, longer amplitude units will be recruited earlier, and maximum recruitment efforts will show greater than normal amplitudes, often with quiet periods of baseline activity. In the extreme, when only a few motor units are functional, the so-called picket fence recruitment pattern will be observed. Low amplitude but full interference patterns with maximum effort are seen in myopathic diseases. Electrical activity appears to be greater than the forces generated by the muscle contraction would suggest. This presentation has been made in the hopes of offering examples of the commonly encountered abnormal potentials as they occur in a typical clinical setting. Additionally, we have reviewed the current concepts regarding the pathogenesis for these phenomena. We hope that this has been a valuable introduction to the art and science of clinical electromyography.